abscess, or tartar. Unlike soft plaque, calculus forms when dental plaque stays on teeth for too long. Minerals from saliva, mainly calcium and phosphate, harden the plaque into a stone-like deposit. Calculus creates the perfect hiding place for harmful bacteria. This can lead to bad breath, bleeding gums, gum disease, and even bone loss around the teeth. Dentists remove calculus through a procedure called scaling. Ultrasonic and hand instruments safely clean deposits above and below the gum line. Regular dental scaling helps prevent gum disease and keeps your smile healthy. Subscribe to Dr. Sila Biolabs. Every subscription supports dental education and awareness.
Hello everyone, welcome to Dr. Sila Biolabs. Today we will be discussing the physiology of dental scaling and calculus formation. Yes, why do we need scaling and how the calculus is formed? You know that yellow substance formed on your teeth when you don't brush for some time? Now, understanding the science of oral health, from plaque to calculus formation. First, the thing is formed is called the pellicle. It's a soft layer. We will be discussing each and everything in detail. Then the plaque is formed, and then the calculus is formed, and then the mature calculus. Okay? This is how the calculus is formed. The pellicle is a salivary proteins coat the tooth surface within the minutes. That is the pellicle. And mature plaque. What is the plaque? Bacteria adheres to the pellicle. The bacteria in your mouth adheres to your pellicle, multiply and form a biofilm that is called plaque. Calculus. Minerals in the saliva or gingival clavicular fluid precipitate into the plaque. That is the calculus formation. And then how the mature calculus is formed. Calculus hardens, becomes porous and promotes further plaque retention. That is how the mature calculus is formed. Today, we are diving deep into the topic that is critical to a tooth, both daily oral hygiene and clinical periodontology. The physiology of dental scaling and calculus formation. Whether you are a patient wondering why a hygienist scrapes off your teeth, or a medical student looking to master the biochemistry of biomineralization and periodontal disease, this comprehensive lecture is designed just for you. Let's break down the science of a healthy smile. Understanding the why. Value the care. Keep smiling. Dr. Sila Biolabs. This will be our lecture. And you know, healthy gums doesn't just happen. They are engineered through science, care, and consistency. In today's lecture, mastering the physiology of dental scaling and periodontal diseases, diving deep into the biochemistry of biomineralization and calculus formation, and a comprehensive lecture designed for students and patients seeking the clear science. Here at Dr. Sila Biolabs, our mission is to empower medical education and simplify complex oral biology. In today's video, we are going to explore dental scaling, why it is necessary, how simply plaque transforms into calculus, the biochemical triggers of bad breath, what physiology happens during the healing phase after a deep clean. We will also address some common patient anxieties such as temporary sensitivity and why teeth can sometimes feel slightly lighter, looser right after scaling. So let's get started. So actually what dental scaling is? Scientifically, dental scaling is a non-surgical periodontal procedure. It involves meticulous mechanical removal of plaque, bacterial biofilm toxins, and hard calcified minerals deposit from both supragingival, which means above the gum line and subgingival below the gum line. Two surfaces, supragingival and subgingival, above the gum line and below the gum line. You can see supragingival above the gum line, the calculus is formed. And below gingival line, that is subgingival, below the gum line. Okay, beneath the roots. Not beneath, just below the gum line. Okay. Dental scaling is a precise, non-surgical therapy that removes the plaque and calculus from above and below the gum line to restore the oral health and promotes the natural healing. Now, what is the clinical objective? The ultimate clinical objective here is to eliminate the local irritants, restoring a biological, clean, smooth root and enamel surface so that your gums can naturally reattach and heal. You can see before scaling, the gums swollen, the calculus is here, and after scaling, you can see clean tooth surface, healthy gums, reduced inflammation, support and reattachment of the gums. Before scaling, what it was? Plaque, tartar, calculus, bacterial toxins and inflamed gums. You can see. Okay? So scaling is just a non-surgical procedure, mechanical removing of the plaque, bacterial biofilm and hard calcified mineral deposited supragingival and subgingival. Okay? Clinical objective was restoring a biological clean smooth root and enamel surface, enabling the natural gum reattachment and healing. Now, why do we need scaling? Why do we need scaling? Home care has its limits. Toothbrush and floss are excellent at disrupting soft and uncalcified biofilm. Mineral fusion occurs if plaque is left undisturbed. This plaque, if left undisturbed for some time or a short period, it begins to bind with calcium and phosphate minerals that present in your saliva. Bone defense is compromised. Once this chemical fusion occurs, the plaque hardens into the calculus. Brushing will no longer remove it. If left untreated, the calculus is physical shield for active bacteria which secrete toxins that slowly destroy the surrounding periodontal ligament and alveolar bone. These toxins, what does they do? They secrete toxin. These bacteria secrete toxin which slowly destroy the periodontal ligaments and alveolar bone. I will be showing you some differences between plaque vs calculus, the transitions of the plaque to calculus formation. Now plaque, you can see it's a soft, sticky and colorless, pale yellow, non-calcified, amorphous biofilm. This is the plaque. But the probe I will be showing you, this is the plaque. And calculus, it's hard rock surface, yellow to brown calcified mineral deposits. Okay, this is calculus. Now composition. 80% of the, now we are discussing the discussion of plaque first, okay, composition of the plaque. 80% of the organic salivary glycoproteins, mucins and lipids, and 20% of inorganic contains living bacteria and byproducts, while the calculus is 80 to 90% of the calcium phosphate crystals, hydroxyapatite, octocalcium phosphate, and 10 to 20% of minimal or no living bacteria. Plaque, yeah, it can be easily removed at home from toothbrushes and dental flosses. But calculus, it cannot be removed at home, requires professional. Removing uses ultrasonic scalers or hand curates. health threat, plaque, it can lead to gingivitis, cause mild reversible inflammation, redness, swelling, and bleeding. Okay? It will trigger gingivitis, reversible inflammation, redness, swelling, and bleeding. But calculus, it causes periodontitis, leads to chronic inflammation, and pocket formation and permanent bone loss. You can see what calculus is doing. What calculus is doing? Chronic inflammation, periodontal pockets, and destruction of the bone. That's what calculus is doing. So plaque is the cause, calculus is the consequence. Remove the cause early to prevent the irreversible damage. Plaque, gingivitis, calculus, and then periodontitis. That is irreversible. So professional care makes the difference. Okay, so what plaque to calculus? As we discussed, plaque, soft, sticky. Calculus, rocky hard. Plaque has salivary proteins and living bacteria, while the calculus, calcium phosphate crystals. Okay, plaque can be removed by brushing and flossing, and calculus, it can be removed by scalers and curates. Plaque, mild reversible inflammation, and calculus, permanent irreversible bone loss, periodontitis. Now let me describe the main culprit dental calculus in detail. Think of a calculus as a fossilized plaque. When a soft biofilm is left undisturbed along the gum line, it acts as a scaffolding matrix. Over time, minerals, salt precipitate into this matrix. Although the calcified core of the calculus consists of largely fossilized bacterial cells, its outer is extremely rough and porous. Calculus is bacterial reservoir. This is rough porous that makes calculus the perfect harbor of a new life, highly pathogenic. Colonies to attach, multiply, and constantly secrete destructive toxin directly into the gum tissues. Bacteria attach to the rough surface, bacteria multiply and form colonies, bacteria release toxins. Now, toxins penetrates gum tissues and causes destruction. See the pathogenic reservoir, dental calculus. Now, fossilized biofilm, calcified forming a dense matrix, rough porous surface, you can see, not solid, extremely irregular topography. Bacteria harbor the perfect safe house for pathogenic colonies to attach and multiply. Bacteria constantly secrete toxins into the gum tissue. Outer porous matrix, you can see. These are the bacteria secreting continuous toxins to your gum tissues. Pathogenesis step by step. First, the pellicle is formed within minutes of brushing. An acellular protective film of salivary glycoproteins. The acquired pellicle coats the enamel within minutes. Then, biofilm, that is plaque. Bacterial colonization within 24 hours. Primary bacterial colonizes adheres to the pellicle and multiply to create a dense biofilm. Then mineralization of the calcium phosphate begins. Calcium and phosphate ions from the saliva start to precipitate into the matrix. Then fossilization of the plaque, maturation of the calculus by the day 12. Fossilization, maturation of the calculus by the day 12. The deposit matures into the fossilized, rock-hard crystalline structure that is permanently locked onto the tooth surface. Calculus provides a retentive surface for more plaque formation, protects bacteria from the host defenses, and contributes to gingival inflammation and periodontal disease. So remove early, prevent damage, and preserve your health. Phase 1, acquired pellicle, salivary glycoproteins. Phase 2, plaque biofilm within 24 hours. Phase 3, mineralization begins. And Phase 4, fossilized maturity by the day 12. Okay, leading to the calculus. Acquired pellicle, salivary glycoproteins, primary bacterial colonizes adheres. At Phase 2, Phase 3, calcium and phosphate mineralization centers, and mature fossilized structure, rock hard, locked to the tooth. Okay, the role of saliva in calcification. A fascinating physiological paradox lies in the role of our saliva. Saliva is biologically supersaturated with calcium and phosphate ions. Under normal conditions, this is wonderful protective mechanism. It continuously remineralizes and repairs our tooth, protecting us from decay. However, if the plaque biofilm is present, this plaque biofilm is present there, saliva act as double-edged sword, near salivary gland ducts, like those under your tongue, behind your lower teeth. Local pH changes triggers the spontaneous precipitation of the rich minerals directly into the soft plaque, cementing it into a hard tartar. What is the composition of dental calculus? 90% of mineral origin. Dental calculus is approximately 90% minerals by weight. That is calcium 65 to 75, phosphate 15 to 20%, carbonated magnesium 5 to 10%. The majority comes from your saliva, where calcification begins. Now, I've told you the salivary gland ducts of water, open under the tongue, behind the lower front teeth, delivering saliva rich in minerals. pH changes, local pH increases, becomes more alkaline around the plaque, promoting mineral precipitation. Mineral precipitation, calcium and phosphate ion precipitates into the plaque biofilm, hardening it into a dental calculus. That is a tartar. Understanding through the diagram, I'm showing you the diagram also. Saliva is basically biologically supersaturated with calcium and phosphate ions, essentially for enamel and remineralization, good and good of course, and spontaneous plaque formation, plaque calcification, that is bad. Saliva, openings of some gingival gland duct, soft plaque is formed, and then mineral precipitation hardened to the plaque tartar. Now, why the calculus is so hard? The biological concrete analogy. Civil engineering concrete, aggregate, cement, binding result, right? This is the concrete civil engineering. Actually, calculus is just not a hardened plaque. It is mineralized, fossilized mass where organic and inorganic components are interlocked, just like a concrete. I told you in the calculus what it is: biological aggregate, bacterial cell, extracellular, polymeric substances, and debris provide the organic framework. Mineral cement, precipitated calcium phosphate, salt, and hydroxyperoxide, octocalcium phosphate. Binding result, a dense crystalline mass that is highly mineralized, irreversible, and extremely resistant to removal. Okay, why the plaque? Why the calculus? It cannot be just removed from the brush. The mineral crystals penetrate and lock into the microscopic pits and irregularities of enamel and cementum, creating a mechanical Interlock. This cannot be removed or rinsed away by brushing or through mouthwashes or through floss. The floss removes the plaque between the teeth, but calculus is fused to the surface. Through the mouthwashes, chemical, it cannot be removed. Just toothbrushes are too soft. So once the calculus is formed, it requires professional mechanical removal with ultrasonic scalers and hand instruments designed to break the mineral aggregate bond. Professional removal is essential because biology built it strong and only science can remove it. To look at its biology chemical perspective, the inorganic mineral content of calculus shifts through a different crystalline phases at its ages. Yes, it is also different crystallines, like a mature calculus, hydroxyapatite, young calculus, brushite, and subgingival calculus is called widlockite. Common in subgingival pockets, magnesium containing calcium phosphate. Okay? First, the mature is hydroxyapatite, crystalline phase, calcium phosphate hydroxide. Second, the soft or young calculus is called the brushite, dicalcium phosphate dihydride, and the subgingival is called widlockite. Here is a chemical, you can see. On it, I can show you calcium phosphate and hydroxide. This is the brushite, and this is the widlockite subgingival. Why it matters now? These different crystalline phases reflect the age, environment, and location of the calculus. Understanding them help the clinician evaluate the age and density of the patient's deposit and plan the appropriate treatment. Young brushite maturing transition to the mature hydroxyapatite. If it is subgingival, it's widlockite. Young calculus, brushite. Then hydroxyapatite, mature calculus. Then the subgingival into the pockets, periodontal pockets, is widlockite. Mineral transformation over the time, plaque, young calculus, mature, and deep calculus. So clinicians evaluate the calculus age density using these phases to guide the periodontal treatment. The pathological symptoms: bad breath, tooth destruction, and permanent jawbone loss. Bad breath, tooth tissue destruction, and then permanent jawbone loss. Now that we understand that calculus is chemically and biologically, let's explore the destructive pathology. How exactly does this calcified rock trigger severe bad breath, tissue destruction, and permanent bone loss? How does this do? Okay? First, coming to why calculus caused the bad breath. The mechanism of halitosis, bad breath. Anaerobic bacteria, lack of airflow, deep deoxygenated shelters, breeds destructive anaerobes. Lack of airflow. It's going in the periodontal pockets, you can see. Then, debris trapping, biological sponge, it acts like a sponge, collecting all the rough porous surface, traps food and dead cells. Okay, it collects the food, traps food and dead cells. Then the toxin secretion, that is the foul smelling that comes from your mouth. Toxic waste, anaerobic bacteria, trap debris. Bacteria ferment the trap debris, release toxins. That leads to bad breath. See, low oxygen environment, anaerobic pockets. Calculus creates deep physical shelters under the gum line because oxygen cannot easily reach there. It creates perfect breeding ground for highly destructive oxygen-hating anaerobic bacteria. Then you can see debris trapping, food particles, dead cells. The rough porous surface, it acts like a sponge, trapping the food debris in dead cells which decompose. Then coming to the toxin secretions. These anaerobic bacteria feed on this trapped debris. They continuously ferment nutrients and release foul-smelling toxic waste directly into their mouth. So, the combination of anaerobic bacteria, decomposing debris, and toxic secretion creates a persistent source of foul odors. That is chronic bad breath. The biochemistry of halitosis. Let's look at the organic chemistry behind that smell or behind this odor. The offensive smell of halitosis caused by volatile sulfur compounds. These gases are produced when anaerobic bacteria break down the amino acids. Hydrogen sulfide, methylcaptan. No, hydrogen sulfide smells like a rotten egg. When it comes to methylcaptan, pungent odor of just like a rotten cabbage. Oh, yuck. And then the dimethyl sulfate adds as a sweet, heavy, musty undertone. That leads to bad breath. This is mechanically the calculus that has to scale away, eliminating the anaerobic harbors where these bacteria live. So the only way to permanently cure this type of bad breath is to mechanically scale away the calculus, eliminating the anaerobic bacteria, their harbors where they are bacterial life. Volatile sulfur compounds, the primary cause of halitosis, thrive into the deep pockets, these bacteria. Okay, two locations of the two distinct hazards. That is, I told you previously also, the supragingival calculus and the subgingival calculus. Okay, the supragingival calculus above the gum line, you can see above the tooth, you can see it highly visible, color texture yellow, white, chalky, mineralization source, saliva, and hazard, aesthetic, and hygiene challenge. When it comes to subgingival, okay, deep within the periodontal pockets, brown or green color, mineralization source, serum from the bleeding gums. Primary driver of chronic bone destruction. Again, giving you a rough summary. This is above the gum line, yellow, white, from the saliva, highly visible, represent aesthetic and hygienic challenge. And subgingival, you can see brown, green, or black, mineralized serum, blood driving proteins. Location forms deep within the periodontal pockets, primary driver of chronic bone destruction. While both are harmful, subgingival calculus is the most destructive threat to your oral and systemic health. Coming to the danger of the gum recession, as the subgingival calculus accumulates, it creates physical and biological hazard. Because the calculus is covered in active toxic bacteria, your body's immune system recognizes a massive chronic infection. In an effort to retreat and protect itself from these bacterial toxins, your delicate gum tissue and the underlying jawbone begins to pull away. This localized retreat is what we clinically call the gum recession, leaving the sensitive root surface of your tooth exposed. Gum recession is not just a cosmetic issue. It is a clear sign of chronic infection and beginning of the irreversible damage. Toxic bacteria. Calculus is a reservoir for harmful anaerobic bacteria. Immune response, the body recognizes as chronic infection. Tissue retreat, gum tissue pulls away from the tooth, escape from the bacterial assault. Root exposure, recession exposes the sensitive root surfaces leading to pain, And bone loss over time, the underlying jaw bone is already resolved. Massive chronic infection, bacterial toxins, immune response, localized retreat, and exposed root surfaces. Fine. And the subgingival calculus accumulates, it creates severe physical and biological hazard. Because the calculus is covered in active toxic bacteria, your body immune system recognizes a massive chronic infection. As I told you, in an effort to retreat the protect itself from the bacterial toxins, your delicate gum line and tissue, what does they do? They pull themselves away from the jawbone. This localized retreat is what they clinically call the gum recession, leaving the root surfaces of your teeth exposed. This bridge erosion. This is a massive continuous calculus block, not supporting the tooth structure, of course. A solid temporary wall of mineralized growing teeth in an unhealthy position. Silent bone destruction deep beneath the bridge is a chronic infection actively dissolving your jawbone. As a jawbone density melts away, the calculus bridge acts as a visual shield, hiding the extent of damage. Splinting teeth, this rigid artificial cement provides a false sense of stability. The patient perceives strength while in reality the underlying support is compromised and the teeth are held by the disease itself. Now what is the scaling? The scaling procedure. Demystifying professional cleaning, temporary sensitivity, exposed dentine can react to temperature and pressure during healing. Temporary mobility, teeth adjust to the removal of the rigid, stabilizing disease, splint as a support structure. Okay, now let us demystify the actual dental scaling procedure. What's happening during the professional clean and why do patients experience temporary sensitivity and mobility afterwards? First, we do the exam and assessment. We examine your gums, measure the pockets, and take x-rays. Then the ultrasonic scalers we used, or hand instruments, carefully to remove the plaque above and below the gum line. Smoothing the surface, of very smooth the root surfaces, helps the gum to reattach to make it harder for bacteria and stick in the future. Polishing and rinsing. We rinse thoroughly and polish your teeth to remove surface stains and leave your mouth feeling clean. Post-op, we provide personalized care instructions to support healing and reduce sensitivity. Healing begins, gums start to heal, inflammation decreases, and your foundation becomes stronger over time. When calculus is removed, teeth may feel sensitive to hot and cold pressure. They also may feel slightly loose. This is temporary and normal. It's a sign that infection and artificial splint are gone and your mouth is beginning to heal. Recovery is a part of the process. Sensitivity typically improves within 1 to 4 weeks. Mobility improves over several to months as the gum and bone heal and re-stabilize your teeth naturally. So clean today, heal tomorrow, stronger smile for your life. How scaling is performed: ultrasonic and hand scaling methods. Ultrasonic scalers, high frequency microvibration gently shatters the mineralized calculus without scratching enamel. Water lavage spray we use, in scaler water is coming continuously, pulls instrument tip, flushes the pathogens, blood and tartar from the pockets. Specialized hand instrument. Fine hand finishing smoothens they smooth the root surfaces, leaving them clean and resistant to the plaque. Use ultrasonic scalers, water lavage spray, and hand scaling. The goal of scaling is not just to remove what's visible, but it's to clean where the disease hides. Remove infection source, preserve bone, and gum health protects your natural teeth. Okay, patient comes to us. They say, The common complaint is, my teeth were not sensitive before you cleaned them, but now they are. Now let's explain the physiology behind this. It was covered with a hard calculus. Before scaling, it was covered with a hard calculus. It's blanket that isolates the root. Think of a calculus as a dirty, insulated blanket. When we remove this cold, hot and cold blocking minerals shield, the underlying roots are suddenly exposed to the oral environment. After scaling, root surfaces are now exposed. Exposed dentine tubules and nerves. But don't worry, it will heal with time. This exposes thousands of microscopic channels called dentinal tubules, which leads directly to the tooth nerve. Sudden exposure, temporary sensitivity to hot, cold, or air. As your mouth continues to oral heal, when they start healing, the sensitivity will improve and eventually disappear. Resolving gums. Because of the calculus, the gums were so much inflamed. Swelling gum line over the tooth neck. And the healing occurs after scaling. Gum shrinks to a healthy level, exposing to the tooth neck. Most patients improve within 1 to 4 weeks using desensitizing toothpaste and proper home care. It can speed up the process. See how sensitively sorry for the interruption. Exposure of the dentinal tubules, dirty insulated blanket, and sensitivity triggers. When we remove this calculus, what happens? This all is exposed, leading to sensitivity. Resolving gums, swollen gums, and then the healthy gums. As gum heal, they shrink to their healthy size, exposing to the tooth neck. So post-sensitivity is normal. It's temporary sign of healing. Now some patient came and say that our teeth feel loose after scaling. See this. This is the calculus bridge. A sudden alarming sensation of slight tooth movement after treatment. Unmasking the damage. We remove this bridge. That is joint. This is joint from here, this joint from here. And it's causing the gum recession. When we remove it, the teeth slightly feel mobile. The clear part for gums and remaining ligament to tighten and heal around the roots. It takes some time. When we remove the rigid calculus, it reveals the underlying bone loss from the prior infection. Gone. It takes time, but it's happening. So after scaling, your mouth needs time to adjust. It can feel that the infection caused over time. Feel slightly mobility temporarily. Pinchable reattachment. Now that physical barrier of tartar is removed, the biological path is clearly for your gums and remaining ligaments to tighten and heal around the tooth. Mobility improves as a healing progress. With good home care and regular maintenance, your gum line stabilizes, returns. Thank you for taking the first step towards a toxins are gone. Gums are healthy. The gums will heal. Don't worry. Your body immediate healing response. Are gone. Resolving inflammation, protective seal. Your tightened infection, free gums provide a firm, strong, and protective seal around your teeth. The long epithelial junction forming a tight hug again. Swelling and bleeding, healthy tissue, form attachment, immunized protective zone. Okay, what if we don't remove this calculus? Don't remove this calculus. The alternative, chronic, unchecked destruction. What if we don't do scaling? What will happen? To emphasize the importance of this treatment, let's examine the alternative. What happens if the patient refuses scaling and allows this calculus to build up indefinitely? Irreversible damage. Now, calculus keeps binding, building hard deposit, thickening and spreading below the gum lines. Infection continues, bone loss progresses, and then the teeth loosen and fail. So scaling stops the cycle and healing starts. The downward spiral of neglect. Gingivitis, it starts from gingivitis where bacteria causes reversible gum swelling and bleeding. Reversible, early treatable, and damage can be reversed. Periodontitis. If left unscaled, it will progress to periodontitis. The infection moves below the gum line, forming the deep oxygen depleted pockets. Below the gum line, the body cannot naturally clean these pockets. Bone loss. This triggers chronic local inflammation leading to bone loss. Jawbone dissolves to escape the bacteria. Permanent damage, the supporting bone loss is destroyed and cannot be grown back. Tooth loss. Ultimately, this leads to the third tooth loss, where the tooth loses its foundation entirely. It falls off or must be extracted. So don't wait, don't ignore the signs, break the cycle now. Professional scaling removes the infection, stops the progression, and saves your teeth. Healthy gums, strong foundation, lasting your smile. The diagram I will show you gingivitis, then periodontitis, bone loss, and then tooth loss. From inflammation to tooth loss, break the spiral. You have to break the spiral of neglection. Severe infection and abscess, a silent infection, a serious threat. As subgingival calculus travels deeper, it seals off the periodontal pocket, turning it into a highly pressurized anaerobic bioreactor. Seal pocket, anaerobic bioreservoir. Deep pockets, pus formation, abscess. Bacteria hide deep below the gum line before you can reach them through brushing. Pus formation with white blood cells resulting in the pus pungent discharge. Abscess, if drainage is blocked, a thrombing pain periodontal abscess forms. Okay, the risk of delay, severe pain, thrombing, constant, deep, and often unbearable. Facial swelling, infection can spread, causing visible swelling, fever, and systemic distress, and bone destruction, of course. The silent infection continues to dissolve the supporting bone. So, delaying the scaling out of fear of the losing teeth only allows the silent infection to dissolve your bone. So, professional scaling stop the infection, save your teeth, and protect your health. So 80% of the bone loss potential, irreversible process, severe disease, and root exposure. Okay, alveolar bone loss and the tissue destruction. Healthy teeth, healthy gums, and full alveolar bone support. Gingivitis, inflammation continue to the gums. Early periodontitis, below the gum line, bone loss begins. Moderate bone loss, continued infection destroy the bone, keeping the pockets. Severe bone loss, extensive bone loss, destruction, teeth become unstable and then it falls off. What does 80% of the bone look like? Teeth lose their foundation, chewing becomes difficult, teeth become loose and shift, greater risk of tooth loss and infection. You can see it through this. This is the healthy foundation, is standing straight. Severe bone loss, it's trembling in the mud, just like trembling in your mouth. For medical and dental students, bone loss is largely irreversible process, while gum tissue can heal and reattach. Once the alveolar jawbone is destroyed by the chronic periodontitis, it is good for good. Severe untreated periodontal disease can destroy up to 80% of the bone loss and the tissue structure. Regular scaling is the only way to stop this destruction in its tracks. So don't wait for the bone loss, prevent it, protect your teeth, protect your health. Early intervention today is a stronger smile tomorrow. So this periodontal disease is not just an oral issue, it affects your overall health of the body. Cardiovascular disease, bacteria and inflammatory cytokines from the gum infection increases systemic inflammation. Cytokines to arterial plaque formation increases the risk of heart diseases and heart attacks linked to strokes and vascular events. Diabetes control, chronic gum infection worsens the insulin resistance, making blood sugar incredibly difficult to control. Poor glycemic control, increased risk of diseases. Respiratory health, inhaling the oral pathogens can lead to bacterial pneumonia, especially in elderly or medical compromise. So your oral health is connected to your overall health, healthy gums, healthy body, healthier life. Regular scaling and periodontal care protects more than just your smile. It protects your smile. Don't ignore your gums. Treat periodontal disease. Protect your teeth. Preventing the calculus formation, brush twice a day. Floss. Use alcohol-free antibacterial mouthwashes. Brush, floss, rinse. Professional care. So daily care plus professional care. A lifetime of healthy teeth and gums. So our educational mission, outreach, expand access to dental health globally, mentor of the future of the dental researchers, engage in the community, get involved with Dr. Sila Biolabs, join our network. Our mission is empowering the minds, improving lives. Dr. Sila Biolabs is dedicated to advancing global oral health through science, education, and community engagement. So join our mission. Let's share, inspire. Together we can build a healthier world, one smile at a time. Stay connected. Knowledge today, healthier tomorrow. So our dual video mission was for patients worldwide, demystifying the oral care of oral biology, breaking down the complex dental pathogens into clear, practical concepts that help you control your health. For medical and dental students, provide high shield, scientifically accurate and visually engaging study aids to help ace your boards, excel in your clinical rotations, and master your periodontal sciences. Our mission, demystifying the oral care, understand your oral health, practical tips, prevent, and for medical students, high yield content, scientifically accurate, visually engaging. Thank you for watching. Stay tuned and stay informed. Stay healthy. Together, we build a healthier world. Dr. Sila Biolabs, where science meets education and compassion. Thank you for watching. Thank you for joining us today in the clinical lecture. If you found this helpful, explanatory, please hit the subscribe button to join the Dr. Sila Biolabs community. We are here to help your master medical sciences. Subscribe, join the community. If you are a patient with questions about your teeth or a medical student looking for academic guidance, please leave your questions in the comments below. I will read it and answer them personally. Dr. Sila, dedicated to advancing health and education. Stay connected. Until the next time, stay curious, keep learning, and take care of your smile. Giving you the image resources. Now subscribe and join the community, Dr. Sila Biolabs. Thank you all. I will join you soon in the next lecture. What lecture you want it to be, you can comment me that too. Okay? Thank you, Dr. Sila Biolabs. Subscribe now.
Did you know a tiny titanium implant can replace a missing tooth and feel almost like your own? This titanium implant is carefully placed into the jawbone, creating a strong new tooth root. Your body accepts the titanium and your bone naturally grows around it. This process is called osseointegration, giving you a strong and natural-looking new tooth. I'm Dr. Sila. Subscribe to Dr. Sila Biolabs. Every subscription helps support donations for cancer patients. Together, we can change lives. Bone loss often develops slowly over months or even years. At the same time, periodontal pockets usually become deeper. This allows bacteria and calculus to spread farther beneath the gums. As supporting structures are lost, the tooth may begin to feel less stable. The greater the bone loss, the greater the risk of tooth mobility. Some patients first notice this when chewing or biting. Dentists often evaluate bone levels using clinical examinations and dental radiographs. Without treatment, bone loss can continue and eventually threaten the survival of the tooth. But periodontitis causes more than bone loss. It is also a major cause of persistent bad breath. Bad breath, also known as halitosis, is one of the most common complaints associated with calculus buildup. The problem usually begins with bacteria living on plaque and calculus. The rough surface of calculus provides Many of these bacteria thrive in deep periodontal pockets where oxygen levels are low. As these bacteria digest proteins and debris, they produce waste products. Some of these waste products are sulfur-containing compounds. These sulfur compounds are largely responsible for the unpleasant odor associated with bad breath. The greater the bacterial activity, the stronger the odor may become. When calculus remains untreated, it continuously supports bacterial growth. Many people attempt to solve the problem using mouthwash alone. While mouthwash may temporarily mask the odor, it often does not eliminate the underlying cause. If bacteria remain protected within calculus and periodontal pockets, the odor frequently returns. This is why professional scaling is often an important step in controlling chronic bad breath. Removing calculus reduces the surfaces where bacteria can accumulate. As gum health improves, bacterial activity and odor production often decrease. Many patients notice fresher breath following successful periodontal therapy, but the consequences of periodontitis extend beyond bad breath. In the next section, we'll discover how gum disease eventually leads to tooth mobility and instability. One of the most concerning effects of advanced gum disease is tooth mobility. To understand why teeth become loose, we must first understand how teeth are normally supported. Each tooth is supported by bone and a network of specialized fibers called the periodontal ligament. Together, these structures keep teeth stable during chewing and biting. During periodontitis, the periodontal ligament gradually loses its attachment to the tooth and bone. At the same time, the surrounding bone may begin to resorb. As more bone is lost, the tooth has less support holding it in position. The result is tooth mobility. Patients may notice movement when chewing, biting, or touching the tooth. Gum recession often accompanies this process, exposing more of the root surface. Many patients report that their teeth appear longer than before. The mobility is not caused by scaling. It is caused by the loss of supporting tissues from periodontal disease. In some cases, large calculus deposits can partially mask existing mobility. The hardened deposits may temporarily make teeth feel more stable than they actually are. Once the calculus is removed, the true condition of the supporting tissues becomes apparent. This is one reason some patients notice looseness after scaling. Fortunately, removing the infection gives the tissues the opportunity to heal. In many cases, stability improves as inflammation decreases. But another common question remains. One of the most common questions after scaling is, why do my teeth feel sensitive now? answer this, we first need to understand what calculus has been hiding.
In many patients, gum disease has already caused gum recession and root exposure.
When scaling removes these deposits, the root surfaces become exposed to the oral environment. The scaling procedure does not create...
Unlike enamel, root surfaces contain microscopic channels called dentinal tubules.
These tiny channels communicate with the inner portion of the tooth. When cold, hot, sweet, or acidic stimuli reach these two...
The nerves interpret this as a brief, sharp sensation.
As inflammation decreases, the gums begin returning to a healthier shape. During the healing phase, the tissues gradually adapt to the new environment. Many patients benefit from desensitizing toothpaste during this period.
For many patients, the sensitivity is temporary. The long-term benefits of removing infection greatly outweigh this temporary discomfort.
Scaling removes the cause of disease and allows healing to begin. Cleaner teeth, healthier gums, and fresher breath are all part of the recovery process.
In next step, we will show you dental clinic and explore exactly how scaling is performed.
Before scaling begins, a thorough dental examination is performed to evaluate the overall health of the teeth and gums.
Sir, the dentist looks for plaque, calculus, inflammation, and signs of gum disease chair, paying particular attention to
The depth of gum pockets is measured. In healthy gums, these spaces are shallow. Deeper pockets may indicate periodontal disease.
3, 4, 7. Radiographs reveal bone loss.